we are beginning with the digestive system and it will be divided into 3 parts. So let's begin with the part 1, and this is the 40,000 series and you can expect 6 questions on this system. The human digestive system is the longest system. It consists of the gastrointestinal tract and the accessory organs of digestion like the tongue, salivary gland, then the liver and the gallbladder. Digestion involves the breakdown of the food into the smaller and smaller components until they can be absorbed and assimilated into the body. So when we are going to see the CPT, we are going to see the surgical procedure performed on the digestive system like the lips, mouth, palate, tongue, uvula, and then we have the salivary gland and its ducts, pharynx, adenoid and tonsils, esophagus, stomach, intestine, appendix, rectum, anus, and then the liver, biliary tract, pancreas, gallbladder, abdomen, peritoneum, and omentum. So one of the largest and the longest system. So from this lecture, I have decided to include some of the anatomical important structure related to that topic so that you will remember them better. So this is the hard palate. I have given the definition here. Then this is the soft palate, which is behind, and this structure is called as a uvula. You can see tonsils on both the side, and then you will have the adenoid somewhere behind like this. And then this is the vermilion border, the definition of which is very important. Sometimes they do ask this definition. In the anatomy, it is nothing but the distinguish between the lips and then the surrounding skin. And the uvula, this is an important structure. You must know the gingiva and then the teeth, the primary teeth and then the secondary teeth or the permanent teeth. The primary teeth are 20 in number, the permanent teeth are 32 in number. And this is the tongue, and the tongue has a lot of taste buds on it, which is important for the taste sensation. Now let us understand some important medical terminology which you are going to learn in this particular chapter. So we begin with the stoma, which is also called as a oro, or it is called as a mouth. And so whenever we talk about the inflammation of the mouth, we call it as a stomatitis. Then glosso or lingual is a tongue. So when we say glossitis is the inflammation of the tongue or inflammation of the tongue. Then labia or chilo is the lips. So whenever the reshaping of the lips that happen as a cosmetic procedure, we use the term chiloplasty. Then the dento and odonto is a teeth. So dentogenic is the arrangement, the teeth arrangement. Then the gingivo is a gum. So gingivitis is the inflammation. Rhino is the nose, which we have seen in the previous chapter. Buccal is the cheek. Buccal mucosa is the lining of the cheek from inside, which then genio or mento is the chin. Then some more medical terminologies. Silodino is a salivary gland. So siloadenitis is the inflammation of the salivary gland, or silolith is the nothing but the stone formation in the salivary gland. Then the trachea is a tracheostomy, we know the word. Laryngo is a larynx. So when I use the word laryngospasm, I'm talking about the spasm of the larynx. Pharyngo is a throat. So pharyngoscopy is viewing of the pharynx. Then the thyro is the thyroid gland. Epiglottis is the leaf-like structure that everybody know. Otto is a ear. So otolaryngorhinologist is nothing but another name for the ENT surgeon. Then myringo and tympano is the eardrum and tympanic membrane, and cochleo is cochlea. So some of the words are from the respiratory or the ENT chapter, but they are important from this chapter. So let us learn some more medical terminology which are important from this section point of view, and these are the root word and these are the suffixes. So the root word is a gastro or gaster, which is nothing but the stomach. So we can use the word gastroscopy, or we can use the word gastritis. So you can put these suffixes and try and make the terminology. So when I use the word gastrectomy, that means I am removing the stomach. Hepato is a liver. So if you are doing the hepatomegaly, that means increase in the size of the liver, or hepatitis is the inflammation. Itis is the inflammation. Cholecyst is the gallbladder. So the cholecystectomy is the removal of the gallbladder, or the cholecystoscopy is nothing but a viewing of the gallbladder. Splena is a spleen, so we sometimes use the word hepatosplenomegaly. So enlargement in the size of the liver as well as the spleen. Then pancreato is a pancreas, so we can make the term pancreectomy, that is removal of the pancreas. Adreno, it is the adrenal gland, and then nephro is a kidney. So I can use make the terminology nephrolith, that is stone formation in the kidney. Then entero is the intestine, and if I am doing the enteroscopy, that means I am viewing the intestine. Then colonoscopy, which is you are going to see more often in this particular section, that is nothing but a viewing of the colon. Or we can use the word colotomy, ectomy. Pay attention to these two spelling, because the CPT codes are different, but sometime in a hurry you make a mistake of reading ectomy and tomy. And then we have the word phago, phago or phagia, to eat, to consume. Then dipso or dipsia, that means to drinks. So we have the word polydipsia, and that is the characteristic symptom of the patient who has a diabetes, because they in them there is an increased thirst, and that is called as a polydipsia. Pepsia is a digestion. So dyspepsia is a difficulty in digestion. Emesis is vomiting. So we use the word hematemesis, that is the presence of the blood in the vomiting. Urea is a urination, so we use the term polyuria, that is multiple time urine. Again it is a sign of diabetes. Then we have a proteinuria, presence of protein in the urine. Then you have a hematuria, that is the presence of blood in the urine. And sterco is nothing but denoting the feces. So we can use the word steatoria, stercoria. So we will see some more terminology. So here I have I have given the list of the medical terminology that we will be using in this chapter. So you must know the meaning. Salivary is nothing but the removal of the salivary gland. See, when we use the word ectomy is removal, and saliva is, we have seen, it is a salivary gland. Pharyngeal is pertaining to the throat. Proctocele is nothing but the hernia of the rectum. Hepatomegaly, megaly is increased. Cardiomegaly is increase in the size of the heart. So hepato is the liver, which we have seen in the previous page. Palatoplasty is nothing but a surgical repair of the roof of the mouth, which is nothing but the palate. Proctoscopy is a visual examination of the anal and rectal region. Now, coledocotomy, it is nothing but incision of the common bile duct. If it is a ectomy, we could have removed it, but here it is otomy. That means it is nothing but an incision. Buccal is basically pertaining to the inner surface of the cheek, which is facing the teeth. And enteropathy, here entero is intestine and pathy is nothing but a disease, because we know the word pathology. Pathology is, logy is the study. So pathology is the study of the diseases, and here enteropathy is disease of the small intestine. Now see, this is a very tongue twisting long word. Colodocojejunostomy. Stomy is creating the opening, that much we know. Between the, this is coledoco is nothing but the common bile duct, and jejuno is the jejunum. So you try and break down the medical word, so it will help you a lot. Then some more words: hyperglycemia. Hyper is more, glyco is a sugar, mia is a condition. So the condition where the sugar level is more. Dysphagia is a difficulty or painful swallowing. So remember the word dysphagia, and we have the word dysphasia. Okay, there is a slight change in the spelling, but the meaning changes drastically. Anastomosis is a new surgical connection between the two previously unconnected organs. Then anorexia is a lack of appetite. Steatorrhea is a discharge of the fat in the feces, because steator is nothing but the feces that we have seen. Then melena is a black or tarry stool. Ascites is nothing but the abnormal accumulation of the fluid in the abdomen. Then hyperchlorohydria is a lack of hypochlorhydria. It is a lack of hypochloride acid in the stomach, and regurgitation, which is called as a GERD, where return of the solid and fluid to the mouth from the stomach. So these are very, very important terminology. So we have seen some important terminology. Now in this particular section, we'll be, focusing mainly on the difference between the diagnostic and surgical procedure, esophagoscopy, esophagogastroduodenoscopy, ERCP, then transplant, hernia, and various modifiers which we are using in this particular chapter. So this is the index, and if you see the index of this chapter, you will see that various body parts are written, from the vestibule of mouth, then the tongue, then the dentoalveolar structure, palate, salivary gland, pharynx, esophagus, so on and so forth. So always whenever you are beginning with a new chapter, take just a minute to observe the index of that chapter, so that you pretty much get an idea how to navigate this chapter. So this is the pretty much layout of the chapter, or the section you can say, where the main body part is written in the red color, and below that you will see the subheadings, which are mainly nothing but the procedures, like lips will have incision, excision and repair, then you will have vestibule of mouth, and again the incision, excision. So this format is pretty much repeated for all the important organ of the digestive system, and always take a minute just to see the format of that particular section, so that it is easy for you to navigate that particular section. So this is for the palate, and you will see that these are the code for the palate. The terminology is a palatoplasty, which we have seen earlier. It is nothing but a surgical procedure used to repair a palate, aiming to close the abnormal opening between the nose and the mouth. And you have the various codes. So pay attention what has been done to the palate, whether have they taken the cleft palate, soft and hard palate only, while here it is a for the cleft palate with closure of the alveolar ridge and soft tissue only. So the codes are very specific, and they talk the very specific language. So let us take one example. A 11-year-old patient is seen in the OR for the secondary palatoplasty for complete unilateral cleft palate. Shortly after the general anesthesia is administered, the patient begins to seize. The surgeon quickly terminates the surgery in order to stabilize the patient. What CPT code and ICT codes are reported for the surgeon? So what has happened is the patient is undergoing for the secondary palatoplasty for the complete unilateral cleft palate. Okay, this is important. But what happened here? The anesthesia was given, but the patient began to seizure, and because of that, the surgeon quickly terminates the surgery. And we need to find out both the things. So these are the code which are given, 4220 and 215. These are the two first codes. So we need to first eliminate which is the correct CPT code. 42215 is a palatoplasty of cap palate major revision, and 4220 is a secondary lengthening procedure. Secondary palatoplasty for the complete unilateral cleft palate. So we have a the code here. Now we need to check what is this modifier. So 76 is a repeat procedure by the same physician. 53 is a discontinued procedure. Now in this case, what has happened is the anesthesia was given to the patient, but the patient began to seize, and because of that they had to terminate the procedure, and for that we use a specific modifier, that is a modifier 53. So let us see what's our answer. So our answer is answer B, that is 4220, that is a secondary lengthening, but the procedure was cut short because there was the patient began to siege, and because of and that happened after the anesthesia. So 53 is more appropriate modifier, and B is the correct answer. So let us take one more example. This is the operative report, a very important thing, because in new CPC exam format, they are going to have 10 questions with the operative report. So what is the preoperative diagnosis? It is a lesion, buccal, submucosa, right lower lip. So the buccal is basically the part of the oral cheek from inside, and cheek and the lip from inside, which faces the teeth, that is called as a buccal. And the post-operative diagnosis is also same. The procedure performed is the excision of the lesion of the buccal submucosa, right lower lip, anesthesia given. And we need to quickly go through the procedure, because sometimes we get a lot of information, important information in the procedure. The patient was placed in the supine position. A measured 7.7 to 8 millimeter hard lesion is felt under submucosa of the right lower lip. After application of the 1% xylocaine with 1:1 1000 epinephrine, the lesion was completely excised. The lesion does not extend into the muscle layer. The 8 centimeter wound was closed with a complex mattress suture to the submucosal level and dressed in the typical sterile fashion. The patient tolerated the procedure well and returned to the recovery area in satisfactory condition. So we have this code 40816 and 814. These are the first code. So whenever you have a multiple choice option, try and eliminate column wise. So 40816 is the complex with excision of the underlying muscle, but our wound does not extend into the muscle layer, so we will not require the code 40816. So that leaves with the three option 40814, and which talks about the complex repair. And this has happened because we get the information with a complex mattress sutures. So we will require the first code. Now, what is the second code? What is the 40831 is the closure of the laceration vestibule of the mouth. It is not a closure of the laceration, it is the excision of the lesion followed by the closure that has happened. So we will definitely not require the code 40831. So that leaves us with the option C and D. So let us zero down our final answer. So here we will take the help of ICD-10 code to zero down our answer. And if you see, key 13.70 is basically refer to the unspecified lesion of the oral mucosa, and D10.39 refers to the benign neoplasm of the other parts of the mouth. But now in this case, they have just said excision of the lesion. There is no diagnosis for the lesion. So K 13.70 is more appropriate, and we'll zero down our answer C. So the next important structure is the salivary gland. The salivary gland produces saliva. We have the three pairs of the salivary gland, and they are the parotid gland, which is the largest, located near the ears and secrete the enzyme rich saliva. So here this is the parotid gland. Then we have a submandibular gland, which is below the lower jaw bone, and the lower jaw bone is called as the mandible, and that's why the name is submandibular. And sublingual is below the tongue, and that's why the name is sublingual. Beside these three major salivary glands, there are minor glands also. Now the main function of the saliva is the digestion. Amylase breaks down the starch. Very important, because sometimes they do ask this question in anatomy. Lubrication, moisten the food for swallowing. Then it prevent the infection and maintain the pH of the oral cavity. And it keeps the taste bud active and aids in speaking. So these are the function of the salivary glands. So here again there is a heading of the salivary gland, and then the incision, excision and repair. That format pretty much they follow. Now what are the important guidelines when we are dealing with the question of the salivary gland? First is select the appropriate code based on the specific procedure performed. Have you doing the incision, excision or repair? And even the imaging is also important thing. Xylography is basically viewing of the involves the radiographic imaging of the salivary duct and may require a contrast injection. Then you have to verify the laterality and extent of the procedure before assigning the code, and pay attention to the all the parenthetical notes, because if you see the parenthetical notes here, they have said if the image guidance is performed for the biopsy of the salivary gland, we need to add the code here. So parenthetical notes, reading the parenthetical note properly is at most important all through your CPT book. So let us take some question. The first question is, patient present for the simple drainage of the abscess from the right side of the parotid gland. Remember, the parotid gland is in pair. So whenever you are doing the abscess drainage, we will have to put the modifier RT here, because if you see the code 42300, it is a drainage of the abscess parotid simple, but there is no mention whether it is a bilateral or unilateral, so I'll be putting the modifier RT. And if it is a bilateral procedure done, we will have to put the modifier 50. Then we come across with the second question, patient present for the needle biopsy of the salivary gland, and then the answer will be 42400, biopsy of the salivary gland needle. Now here, since in the question there is no mention of the radiological guidance, I'll be writing only the code 42400. But in case if the radiological guidance is taken, we have a clear-cut instruction, the parenthetical note, that if the image guidance is performed, we need to write this code. So suppose, for example, the ultrasound guidance is performed for this particular biopsy, I'll be writing the code 42400 and then 76942, because this is the code for the image guidance. So reading the parenthetical notes all through the CPT book is at most important. Then the third question is, patient present for the excision of the sublingual salivary cyst. So it is, what has been done, it is the excision of which gland, the cyst of the which gland, sublingual gland, and the code is 42408. So if you see here, the language is very specific. It is a salivary gland cyst, and which is very common, which is called as a ranula, and we have the code which speaks the complete language, so we will be writing 42408. So these are the code for the tonsillectomy. That's our next topic, tonsillectomy and adenidectomy. Let us look at the guideline. Do not append a modifier 50 to the tonsillectomy and adenidectomy code, as these procedures are inherently bilateral. The code range is 42820 to 42836. Now remember, most of the time the doctor will remove both the tonsils, but sometime the situation arises where the doctor has to remove the unilateral the gland, or he has to perform the procedure unilaterally. That time we can use the modifier 52, which is for the reduced services. The code, these codes are age sensitive. So if you see all the code, this code talks about younger than age, while this code talks about age 12 or over. So since the codes are age sensitive, while solving the question, pay attention to the patient age. Now, if you see all these codes, there are code only for the tonsillectomy, there are code only for the adenidectomy, but there is one combo code. The combo code is 42820 and 42821. So if you see the language of this code, it includes both tonsils as well as the adenoid removal. And in your documentation, if the situation is like that, that the doctor has removed the tonsil and adenoids, you can use this combo code over the individual codes. Okay, so this is very, very important. So let us take few questions that will strengthen your guideline. This is a case report. So what is the case report is, preoperative diagnosis is the chronic tonsillitis and chronic adenoiditis. Postoperative diagnosis is same. Procedure is tonsillectomy and adenidectomy. The age of the patient is 24-year-old male who was taken to the operating room and put under IV sedation by the anesthesia department. An initial curettage of the adenoids was done and packaging was placed. The left tonsil was then identified and dissected out extracapsular and removed with scissors. Hemostasis was maintained by packing the left tonsil. Next, the right tonsil was identified and incision was made. Dissection was done, extracapsular, and the right tonsil was then removed. Both the right and the left tonsils were sent as a specimen as well as the adenoid tissue. What are the procedure and diagnosis code? So let us see what are our options. So first is whenever there are multiple options, begin with the first column. Now in this case we have the code 42826 and 821, and these are the two different codes. So what is the 42826? It is the code for the tonsillectomy, primary or secondary, younger than 12 years. What is the age of the patient? 24 years. So we cannot take this code. 42826 is the code for the 8-12 years are over. So we will require this code. But wait, what is this? This is the case of tonsillectomy and adenidectomy, and for which I told you that we have a combo code. And whenever there is a combo code present, we will pick up that code over the individual code. So what is the code 42821? This is the indented code. So I will read the above code: tonsillectomy and adenidectomy, age 12 years or over. And that's what happened. These two procedure along with 24 year, the age of the patient. So 42821 is the code. So that will eliminate option A and C, and we are left with a B and D option. So let us see what's our answer. Now we know the guideline that there is no need to use the modifier 50 on the tonsillectomy code, and that's why 42821 modifier 50 is not the correct answer, and we will zero down our answer 42821, which is a tonsillectomy and adenidectomy age 12 or, years or over, and always the combo code we will use it. It takes the priority over the individual code, and that's why that's the final answer. A 15-year-old female is to have a tonsillectomy performed for a chronic tonsillitis and hypertrophic tonsil. A McLever mouth gag was put in a place and the tongue was depressed. The nasopharynx was digitalized. No significant adenoid tissue was fed. The tonsils were then removed bilaterally by dissection. The uvula was huge size because of the edema. A part of this was removed and the raw surface oversewn with 3.0 chromic catgut, which CPT code should be used. So what has happened here? There is a chronic tonsillitis, bilateral removal of the tonsil that has happened. But that's not the only procedure that has happened. Along with that, they have removed the uvula. So first thing first, check all this code. What is the code 42821? It is the indented code which talks about the tonsillectomy, adenidectomy. In our case, they have not touched the adenoids. What they have done is only the removal of the tonsil. Now 42825 is the tonsillectomy, primary or secondary, and younger than age 12. We need to consider the age of the patient also. And 42842 is a radical resection of the tonsil, tonsillar pillar, and our retromolar trigon without closure. So this is the decode. So let us see what our answer is. Yes, so C is the correct answer because 42826 is this code. It talks about the tonsillectomy, primary or secondary, and the age of the patient is 12 years or above. Our age of the patient is 15 years. And then there is another procedure that has happened, that is 42106, and that is the procedure for the excision of the lesion of the palate uvula without closure and with simple primary closure. In our case, we have done the closure with the chromic catgut. So 42106 is more appropriate code, and this is the second procedure that has happened. So we will put a modifier 51. So let us take one more example. An ENT surgeon performed a control of uncontrolled bleeding in 14 years old boy after 24 hours of surgery by surgical intervention. The boy underwent tonsillectomy only for the regrown tonsil after the initial tonsillectomy in 12 years of age. Now we have to code for the uncontrolled bleeding that has happened 24 hours after the surgery. So what is the code 42970? It is control of nasopharyngeal hemorrhage, primary or secondary. Example, post adenidectomy. Simple with posterior nasal pack, with or without anterior pack and or cautery. 42962, it is a with secondary surgical intervention. This is indented code. So I'll be reading the code: control of the oropharyngeal hemorrhage, primary or secondary, post tonsillectomy. This is simple, and this is with a secondary surgical intervention. So there is no case of adenidectomy, but this is the case of tonsillectomy. Post tonsillectomy bleeding has happened, and there is a secondary surgical intervention that has happened, and because it happens after 24 hours. So we will require a code 42962. 42826 is, it talks about the tonsillectomy, but today we are not coding for the tonsillectomy, we are coding for the controlling of the bleeding. So 962 is the correct code. Now the modifier will decide our final answer. So let's see what's our answer. So in our case, the tonsillectomy, after the tonsillectomy, 24 hours after the procedure, the bleeding has happened. And so we will finalize the code 42962, and 78 is the right modifier because it is an unplanned return, because whenever the surgery is properly done, we do not expect such return to the operating room, and it is not planned, and that's why more than 58, 78 is the right modifier, and that will decide our answer. So here we have finished till the tonsillectomy. We have part 2 and part 3 of the digestive system that will cover shortly, but pay attention to all the codes, pay attention to all the modifiers, because in digestive system there are many modifiers that will help you to decide the code, and so is sometimes the ICD-10 code.